Hello, good morning, and thank you for coming to my presentation today on the female reproductive system, specifically premenstrual syndrome and endometriosis. So to start us off, I want to hit us with an overview of the female reproductive system. The female reproductive system is composed of organs that assist in the development and expulsion of a fetus in pregnancy and in childbirth. And when it comes to the female reproductive system, there are both internal and external organs that play a role in the overall function. For the external organs, we have the labia majora, labia minora, hymen, clitoris, vesicle, and urethra, and the skin glands. And then for the internal organs, we have the vagina, cervix, uterus, fallopian tubes, ovaries. And then, fun fact, females are born with all the eggs they'll ever have, which at birth is around 2 million, and then by the time the female reaches puberty is only around 300 to 400,000. And out of that very large number, only around 300 ever develop and enter the fallopian tubes. 4 phases of the menstrual cycle and hormones of the reproductive system. The menstrual cycle is a process within the female body that repeats itself monthly from puberty through menopause, and this cycle allows the female to become pregnant. The first day of the menstrual cycle starts with the first day of bleeding and ends the day before the first day of bleeding, which is approximately 28 days, but ranges from about 21 to 37 in most women. There are several phases within the menstrual cycle that are characterized by fluctuations of hormones, estrogen, and progesterone. So the first phase is the follicular phase, which begins with the onset of menses, which is the shedding of the thickened endometrium inside the uterus. This lasts through the day of ovulation, and during this time, progesterone remains low, and estradiol increases gradually up through the mid-follicular phase and will spike dramatically before ovulation. And then ovulation occurs when the mature follicle bursts open and releases an egg from the ovary. Following ovulation, the female encounters the luteal phase, which lasts from the day after ovulation to the day before menses. During this phase, progesterone and estradiol levels begin to gradually increase, and then midway through, they will see a peak in both estradiol and progesterone. And then if the egg does not become fertilized, that's when we have the rapid withdrawal of both of those hormones, which triggers menstruation, and then the cycle again repeats itself. I also want to hit follicle-stimulating hormone and luteinizing hormone really quick. Follicle-stimulating hormone stimulates the growth of the ovarian follicles, which is introduced in the beginning of the cycle, and then luteinizing hormone is going to surge just prior to ovulation and trigger the release of the egg by the dominant follicle. So, what is endometriosis? Well, endometriosis can be defined as having endometrium-like tissue outside of the uterus, which is normally diagnosed through a laparoscopy, which is a surgical visualization. Around 10% of reproductive age women are diagnosed with endometriosis, which equates to 190 million women worldwide. It presents itself in several different ways, ranging from superficial perinatal lesions, which are endometrial-like tissue on the lining of the abdominal cavity, to ovarian cysts, to nodules penetrating over 5 millimeters deep, and these signs are accompanied by scarring and adhesion to extrapelvic lesions. And for females diagnosed with endometriosis, there is no pattern of progression for endometrial lesions. In some patients, they progress, and others, they regress, and in others, they remain stagnant. So it really just depends on the individual. And the same thing can be said with symptoms. So endometriosis is split up into 5 different stages, according to the American Society of Reproductive Medicine. And for symptoms, even females with like minimal stage 1, can have very severe symptoms, and people with stage 5, which is very severe and deep, may be asymptomatic. So it's very highly variable and dependent on the individual. But with that being said, some of these symptoms of endometriosis include acrylic pelvic pain related to the menstrual cycle, dysmenorrhea, which is painful menstruation, dyspareunia, which is painful intercourse, dyschezia, painful bowel movements, dysuria, painful urination, infertility, somosensatory amplification, which is increased sensitivity to bodily sensations, and fatigue. And then we have the types of lesions. So we have those superficial perinatal lesions, which I talked about earlier, and they can be yellow, brown, blue, and black, or clear. Ovarian endometriota, which is ovarian cysts filled with blood. Deep endometriosis, which is lesions that penetrate deeply on the pelvic tissues. The vascularization, which increases the blood vessel formation and supports the growth. Innervation of lesions, which is the presence of nerve fibers, which contributes to more pain. Pelvic cavity scarring, which occurs when fibrous bands of tissue form as a result of inflammation from lesions and again lead to pain and organ dysfunction. And then extrapelvic lesions are lesions that are found outside of the pelvic cavity, which is really rare, but they have seen instances where these are found in the brain. So moving on to diagnosis and hormonal imbalances. A formal diagnosis, like I said, must be done by a laparoscopy. But before that, other non-invasive diagnosis tools can be used, such as MRIs. The origin of the disease is still unknown. However, sex hormones, estrogen and progesterone, play an unquestionable role in the development of endometrial tissue. High estrogen production is a consistent feature of an endometriosis diagnosis. The mRNA and protein levels in estrogen receptors in someone with endometriosis are different than in someone who has a healthy endometrium. In endometriosis, abnormal tissues can make their own estrogen, which accumulates in the body, and this accumulation of estrogen in endometriotic tissue plays a role in the development of lesions by binding and activating to estrogen receptors. For treatment, normally the first treatments are going to include medications such as like oral contraceptives, progesterones, and agonists of gonadotropin-releasing hormone, other androgens, and painkillers. The hormonal treatments for endometriosis are designed to inhibit ovulation and menstruation, which in turn is going to suppress that hormonal fluctuation and decrease inflammation. But typically these aren't like super long-term sustainable since there's other undesirable side effects from these. And then we also have surgical treatments, which again, the laparoscopy, which is not only used to diagnose, but can also be used to locate and remove lesions and adhesions, or the laparotomy, which is used to remove larger lesions and adhesions. And then the last resort would be the hysterectomy, which is when all the other treatments are exhausted. So moving on to PMS, or premenstrual syndrome. Premenstrual syndrome is a condition where around 75 to 85% of women notice at least one physical or psychiatric symptom, and causes a wide variety of symptoms in women ranging from physical to psychological that can have a large impact on their quality of life. The percentage of women who have PMS and struggle with symptoms that are heavy enough to impact their daily lives is around 20 to 40%.
I do like a voiceover.
And the onset of premenstrual syndrome is going to be during that luteal phase and resolve shortly after menstruation begins to occur. There's not a lot known really about the origin of PMS, but several studies have suggested that PMS occurs due to the changes in estrogen or progesterone that occur throughout the female menstrual cycle. For example, the mood changes may be due to the effect that estrogen and progesterone have on the serotonin and dopamine systems. But it should be known, however, that sex hormone fluctuations cannot fully explain PMS. And unlike endometriosis, women diagnosed with PMS don't have higher levels of estrogen and progesterone than the general population. So it's just unknown as to why some women are more sensitive to these fluctuations than others. For the symptoms, PMS doesn't need a surgical diagnosis like endometriosis does, and can be diagnosed if a patient reports at least one of these symptoms during the last 5 days before menses, and it must be reoccurring over the last 3 menstrual cycles. The symptoms include angry outbursts, abdominal bloating, anxiety, breast tenderness, confusion, headaches, depression, joint muscle pain, irritability, social withdrawal, and weight gain. And then treatments for PMS are more focused on the symptoms associated relief rather than an actual cure. And many medications are going to be similar hormonal medications like oral contraceptives, or psychological symptoms can be treated with selective serotonin reuptake inhibitors, or SSRIs. But many women without very severe symptoms may be able to manage their PMS symptoms through NSAIDs or non-steroidal anti-inflammatory drugs like ibuprofen, dietary adjustments, exercise, and even sleep. Both endometriosis and premenstrual syndrome share physiological characteristics. For starters, endometriosis is characterized by pain and inflammation, and although normally less severe, inflammation also plays a role in premenstrual syndrome, and is usually the cause of breast tenderness, bloating, and swelling. Another correlation between the two is the pain pathways that women experience with these conditions. In endometriosis, the women can experience pain sensation, which leads to chronic pain, even in times when there is an absence of lesions and adhesions. In premenstrual syndrome, though less severe than endometriosis, women can experience heightened sensitivity to pain as well, due to the drop in progesterone and estrogen in the luteal phase towards the tail end of the menstrual cycle. And of course, both of them are prone to deal with psychological effects as well. Common hormonal pathways is, whereas endometriosis is known to be characterized by that high level of estrogen in the body, premenstrual syndrome is characterized by increased sensitivity to the fluctuations that occur throughout a normal menstrual cycle, but through the luteal phase to menses to be particular. Impact on daily life. So the impacts of both endometriosis and PMS can be debilitating for the patient. In endometriosis, the patient can be dealing with chronic pain, which can affect their ability to complete daily activities.
And then it's
on top of the chronic pain, many will suffer from extreme menstrual pain, such as cramping that will affect their daily activities. And with this, many suffer with fertility issues as well. And with as much pain and interference as in daily life that they experience, it's fair to assume that they'll also be lingering psychological effects, such as high stress, depression, and anxiety. And for patients with PMS, they can also run into pain issues, normally lasting about 1 week during that luteal phase. So often it's much less severe than endometriosis, but they have to deal with bloating, cramping, severe cases. It can leave them with absences from work, school, and an inability to resume normal activities. In the same way that chronic pain can lead to psychological issues in endometriosis, the same can occur with patients in premenstrual syndrome. So depression and anxiety are often accompanied side effects in women who experience significant mood swings and heightened emotional responses. In summary, the female reproductive system is a profound and intricate system with the overall goal of fertility and childbirth. Within the female menstrual cycle, there are sex hormone fluctuations that play a role in the way women feel throughout the month. In women with premenstrual syndrome, they experience a heightened sensitivity to those fluctuations, and in endometriosis, the patient will have an overabundance of estrogen and abnormal tissues. Although both conditions are not related, they both have similar presentations to start, and often the women will initially be diagnosed with PMS prior to being diagnosed with endometriosis, so it's important to understand the correlation and how they play out within the female's life. But that is all I have for you guys. Thank you so much for coming to my presentation. I hope you all gained some valuable information about the female reproductive system and some of the associated conditions.